Good afternoon. My name is Abby and I will be your conference operator today. At this time, I would like to welcome everyone to the National Disparities 1 event conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during that time, simply press star then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Ms. Marasaris with the Clean NCC, you may begin your conference.
Great, thank you. And thank you everybody so much for joining today. Welcome to the Disparities Learning and Action Network. Today's topic is addressing disparities, best practices for communicating about accomplishments in health equity. You'll hear us talking a lot about quality improvement organizations, QAOs, or Clean QAOs, because that's our primary audience, but the content should be relevant to many others as well. Next slide. I'm your facilitator, Nora Saris, and if I get connected for any reason, my colleague Melanie Wasserman will jump in as our backup facilitator. We're here to learn from each other, so I am counting on you to enrich our discussion today. I would love it if you would share your health equity successes or activities in the chat box, and you can post your questions and thoughts here at any time. We'll pick up on those contributions during our Q&A session at the end. My colleague Naya Luzi will be monitoring the chat box and also posting useful links and questions there. I have a few housekeeping items to review before we jump into the content. Our call is 90 minutes today, and in the first hour, we'll have presentations from our speakers, and I'll encourage you to post questions and comments. Then we'll close the formal part of the call, and we'll stay on the line for up to 30 minutes for an open discussion with you. You'll find the slides and a recording of this call on the QAO program's website in about 2 weeks, and Naya will be posting a link in the chat box. Next slide. So here's our agenda for today. I'll explain how you can get CE credits for attending this event, and then our speakers will share some general tips for sharing stories about positive impact, specific tips for communicating about health equity successes, and some examples of a Clean QAO's current activities to address disparities. Next slide. So here's the purpose of the series, and I've detailed a detailed description of the Disparities Land series. What's the most important to know is that we're here to help you meet your goals for health equity, addressing disparities, and optimal health for everyone. Next slide. And here's what I hope you'll get out of this event, and we'll ask you about this in the post-event survey. As a result of attending today's call, we expect you'll be able to identify the successes worth sharing, describe at least 2 general strategies for effective communication about successes in general, and discuss additional strategies for communicating about health equity successes. If you have other goals for today's call, please post them in chat, and we'll do our best to help you meet them. Next slide. We'll have more fun if you commit to being attentive and active on this call. So go ahead and click the checkbox and send the green check mark if it's showing up for you on the right to show me you're actively listening. If that checkbox doesn't show up, just type yes in the chat box, or I'm here, to show you're ready and actively listen and participate. All right, awesome. Thank you, Rachel. Thanks, Jen and Yeli. Thank you, everybody. I'm excited for this call. So you can continue typing in yes, so please move to the next slide, and we'll talk about continuing education credits. So if you're a physician assistant, a registered nurse, or a nurse practitioner, a dietitian, a pharmacist, or a pharmacy technician, we're happy to offer free continuing education credits by attending today's call. We'll also offer certificates of attendance in case you need one of those. Next slide. So to get the CE credits, you'll need to attend the entire event, complete the evaluation that pops up after the event, and then complete the separate CE evaluation that will load in your browser after you complete the general evaluation. Once you submit your CE evaluation, you'll get a certificate for your record. And hopefully everything will work out perfectly and you won't need technical assistance. But if you do, you can email Patty Nelson, and Naya is posting her email in the chat box now. Next slide. You can reference this slide and the next one in the full CE statement. The main thing to know is that the session is worth up to 1.5 continuing education credits for units or contact hours, depending on what your accrediting body calls them. Next slide. So here's more detailed text, but it's important to know that you can only claim the amount of time you actually spent on this event. So So if you want to claim the full credit, please stay on the line for the entire event. Next slide. So here's our disclosure slide. And the planners and faculty who are involved in the planning and activities have no relevant financial relationships to disclose, nor do we receive any commercial support. Next slide. And here's more on the disclosure. So please use your professional judgment. Next slide. So again, participate in the entire activity and complete the post-evaluation. And then if you have questions, please contact AKH or Patty Nelson. All right. So next slide. Let's get into the call now. So who is in the room? I would love to hear from you all of what organization you're representing. So we'll queue up the polling question, but if it doesn't pop up for you, you can just answer in chat. So the poll should show up for you, and if it doesn't, you can answer it in the chat box. Awesome. Looks like we've got already from Sue and Eric in the chat, we've got a couple of different entities that are being represented right now already. Awesome. So we'll wait for that to wrap up. And thank you, Teresa, as well. I'm glad you're able to join us. I'm sure there will be something for everybody on the call. All right. Great. So next slide, please, Patty. So let's meet our speakers today. And Alexa Newland, Melanie Wasserman, and Brenda Jenkins will be presenting for you today. Alexa Newland is an experienced health communications professional with training in global health. She comes to us from Sage Communications, where she serves as a Program Collaboration Center Integrative Communications, or PCCIC team. This team supports communications for the Quality Improvement Organizations program. Alexa's up first. She'll introduce Melanie and Brenda in detail later on. For now, let's listen to Alexa Newland. Feel free to post questions in your key takeaways in chat. Alexa, you have the floor.
Thank you, Nora. Today I'm very excited to discuss some thoughts and ideas about sharing your good news. Storytelling is a very powerful tool that helps people connect with one another. With a little planning, you'll be able to reach people with information they will find interesting and relevant, ultimately with the goal of strengthening the connection between your work and your target audiences. So next slide, please. So here are some 7 easy steps to help with good promotion. The first is to set a goal, and goals may include boosting recruitment efforts. It could be building your credibility for your organization's work among prospective new partners, sustaining relationships, or possibly winning new business opportunities. Once you have determined your goals, you want to think about the audience in which you're talking with. So based on the goals you're trying to achieve, identify those target audiences, which could be internal staff, it could be existing partners or customers, prospective partners or customers, maybe it's oversight bodies, CMS, or federal health leaders. And oftentimes your communications or marketing department will be the central source of success stories that you want to share. However, it's important to keep an open dialogue from the field to help maintain a fresh supply of new news or something that might be worthy of promotion. These can include testimonials or data-driven results that you've achieved, anecdotes, or patient stories. One thing I found helpful in this is developing an internal shared Google Doc that can be a way to share across departments in real time so that the communications department has access to interesting ideas that they can follow up on when they're ready for it. And then once you've established your audience, the next thing you'd like to do is really establish what's the best communication channel or tactic to reach that audience. For example, if you're trying to show success to leaders of an oversight body and you have data readily available, something that makes sense would be developing an infographic for inclusion in a presentation deck or a briefing deck. If you're seeking to recruit more beneficiaries for a healthcare improvement initiative, perhaps a personal story or something that you could share from other beneficiaries, an article or a blog post might be most relevant for that audience. Other ways you can share your stories or channels would be social media or organizational newsletters, local speaking opportunities are another way. And I'll come back to that in a second. So then we really want to start thinking about, well, we're promoting our stories, but how do we determine what's being effective? So setting a goal that you're hoping to achieve can help you measure that success. So back to an event that you might be hosting for a local speaking opportunity. One way you can do this is make sure that you have a good contact management system to track participants at that event that you can follow up with later. I think I've always found it's the follow-up that really matters. So being able to collect that data up front of who's participating and then continuing to build that relationship. So once you're ready to share your story with your target audience, look for opportunities within that story to incorporate the brand or the organizational messaging within the story itself. So, for example, and we'll talk about this on the next slide, but we'll want to take the QIO program. One of the things we've really found effective is to incorporate some of the brand of the QIO program. Words like collaborative or person-centered or result-oriented, really looking at that brand book that we had established and incorporating language to tie that link back to the story. And then once you've done that, it's time to share your story and measure that impact. Next slide, please. So here's an example of what we've done recently. This was last year's QIO program progress report. And I'm sure some of you listening today might have seen this or come across it. So I just want to walk through a couple of elements that I want to bring to your attention that made for a good publication. It's really important to make sure that you have a visually compelling product. We live in a visual world now, and you want to think about what the images are, the stories the images are telling, in addition to what you have on the written page. So I ask you to consider what do you want to see versus what you have. A lot of organizations are sometimes lacking some of the images, but it's important to pay close attention to how you can tell that story visually as well. And when you tell that story visually, you want to ensure that you have diversity in your images, including age and disabilities. As we move forward, I also encourage you to think about the details. If you're telling a story around immunization, sometimes I've seen where the story has been passed off to a designer and they're not as closely related to the product. So they'll throw in an image with a needle, but that needle is actually a doctor drawing blood and not an immunization. And I'm sure all of us on the call today can relate. There's a significant difference between the two. So just being attentive to those details before it goes to publication. And then you want to make sure images are of the correct resolution, whether it's print at 300 dpi or it's digital for 72 dpi. Those are some challenges that you can think ahead of time that will help speed your project along. And then also I encourage you to ensure that send the original files if you are working with images. Secondly, I'd like to bring to your attention, well, I know that you'll be talking about disparities a little bit later and more specifics, but in the progress report, we were really able to highlight some of the great work some of the QIOs were doing in this space. And we highlighted a story from Great Plains that sought to improve communication among clinicians by implementing a virtual program. And this was something we could collaborate on, tell the story, and incorporate the QIO brand within the story language. So it weaves the program's attributes and vision throughout the stories we share. Next, I also would recommend sharing or creating a toolkit. A toolkit's a great way you can help your network promote your story for you. So toolkits may include posts with hashtags, email templates, talking points. We've tailored toolkits to several of our stakeholders so they can help promote the stories and information relevant to their networks. And finally, we tracked our online traffic, whether they went to see the progress report online or they downloaded it. We tracked media coverage and then social media activities, sharing the links, what was the conversation online in the various social media channels. So these are a few of the examples we implemented in the progress report last year. As we continue moving forward into this next year, we will be doing the same. So as I close, I challenge each of you to think about the goals set out for your program and who among your network can help you achieve those goals. Once you have identified those audiences, start thinking about how to link your good news to their interest areas. Whether the content might be data or patient stories or program highlights. And remember, each audience receives information through channels that are trackable and relevant to them. So that could be a board presentation or a blog post or social media. There is no perfect or no practice makes perfect. There is practice makes better. So don't be afraid. Telling stories is fun, and with a little planning, your stories can make your message relevant to your audience, strengthen and enhance the work you do. And I'm very grateful for these opportunities. So thank you so much. And if you have questions, please don't hesitate to reach out. Thank you. And I'll turn it to Nora.
Yeah, thank you, Alexa. That was really great to hear from you and to hear those strategies and tactics. I think now wrapping up at the end of this statement of work, and also with anybody who's working toward any sort of healthcare improvement or quality, it's important to be able to message those effectively. So I really appreciate all of your wonderful insights. And also thank you to everybody who was on chatting in chat with all of your comments and questions. I invite you to continue to do so as we move forward. Also, if you have any great tips or if you've tried what Alexa mentioned today, feel free to write that in as well. And so on to the next slide. Our next speaker, Melanie Wasserman, co-leads the Disparities Learning and Action Network, and she's a managing consultant at the Learning Group. So Melanie, you have the floor.
Thank you. So I'm going to share some specific tips for communicating about health equity successes from the Disparities Learning and Action Network team based on our experience of the past 3 years. Next. And first I want to talk about why would we want to communicate about health equity successes. Some of you have already shared your reasons with me. You want to celebrate accomplishments, inspire others to address disparities. Bunch of good ideas. And for those of you who haven't shared your reasons with me yet, I'd love to know what they are. So please post in chat and tell me your reasons for wanting to share health equity successes. Next. And before I get to the core of the presentation, I want to acknowledge some health equity communication challenges that affect Quinn QIOs especially, but may also affect other organizations. And the first challenge is identifying activities that you're doing that are addressing disparities. I heard this a lot from folks working at QIOs, that we just don't have time to address disparities. But then when we got to know what you were doing, we realized most of what you're doing actually addresses disparities. So we'll talk about that. There's also a lot of challenges in identifying a comparison group, being able to stratify your data so you can see what the disparity looked like before you started your intervention and after. We'll talk about that. A lot of what you do has effects beyond your contract period, your grant period, or whatever the intervention period is that you're doing. That's a challenge. We'll acknowledge that. And then we'll talk about how do we craft a narrative that's, first of all, accurate, most importantly, but also respectful to the people that you're talking about, inspiring to others, and just generally helpful. Next. So what are you doing that is addressing disparities? If you're doing work that primarily benefits priority populations like persons who are in racial and ethnic minority populations, people with disabilities, members of the lesbian, gay, bisexual, and transgender community, rural populations, and any other population that is affected by disparities, chances are you're doing something that's addressing disparities. You're working with these populations. Or maybe you're doing work that relates to certain concepts: whole person care, social determinants of health, health literacy, plain language, access to care for persons with limited English proficiency, or people with communication challenges, or people with physical disabilities. Or maybe you're a healthcare organization and you're working with professionals and organizations that address a wider range of needs. So community health workers, social workers, EMTs and first responders, faith-based organizations, or other community organizations. If you're collaborating with these professionals, with these organizations, chances are you're doing something that addresses disparities. Next. All right, so the next challenge I mentioned was identifying a comparison group and being able to stratify your data. So ideally what you can show is something like the graphic on the right. So this is from Novant Health, and they won the Health Equity Award from CMS last year. And this shows when they started in 2016, they had a 4% disparity in readmission rates for between African Americans and Caucasians who were admitted to their hospital for pneumonia. And they did a bunch of interventions. And at the end, not only did they eliminate the disparity, but readmissions went down for everyone. So well done. After this event, we'll post on the event registration page both a slide and also a short video where the Novant Health team shares their story in their own words. Really interesting short video. But for Quintos, it's really challenging to stratify data in this way, and there's a bunch of reasons. First of all, it wasn't in the scope of work. So when you have a task that takes a lot of work and it wasn't in the scope of work, and there's some contract issues around that. And then even if you're motivated to do that, the providers you're working with, you're aggregating data from lots of different providers. They all have different electronic health records. And even if they have the data in their electronic health record, which a lot of them do, it's difficult for the providers to extract the data from their electronic health records, and then getting everyone on the same page, if you have a whole bunch of people with different electronic health records, is just really tricky. So I just want to acknowledge that. But if you're one healthcare organization like Novant, you can do it, or maybe a group of organizations with the same electronic health records. Next slide. And then a lot of the work that you do has effects that extend beyond the period of performance. So, for example, Twin QIOs are training diabetes educators to provide diabetes self-management education, and presumably they can continue to provide these services long after the contract ends, but we don't really know if they will or not. And similarly, you're building coalitions for care coordination, and those are partnerships that can last a lifetime, but we're not sure how to assess those future effects. Next. All right. Having acknowledged those limitations, I want to talk about how we craft a compelling narrative around health equity. And where you need to start is with a general statement about what do you seek to advance and to what end, because not everyone in the U.S. and in your audience is on board with furthering health equity and advancing disparities. First of all, a lot of people don't know what that means. And oftentimes we explain it poorly. So to start with a statement of shared values And there's some values like opportunity and choice that transcend political boundaries. Everyone likes opportunities and choices. So here's an example of some language that was tested in a study that was funded by the Robert Wood Johnson Foundation in 2010. And they tested messages with bipartisan audiences to talk about the social determinants of health. And here's one that tested well. All Americans should have the opportunity to make the choices that allow them to live a long, healthy life, regardless of their income, education, or ethnic background. And you can find lots of language like this in the Robert Wood Johnson Foundation report that Naya is going to post a link to in chat. And another source that really influenced us on the disparities land in the past 3 years is a chapter from National Academy's press report on framing the dialogue around health equity, and it says chapter 6 on the link. It's actually chapter 5, and it's a really good read. I recommend it. Next. So here's an example of an organization that shared that mission statement, that made that statement of shared values. Novant Health, again Novant, exists to improve the health of communities one person at a time. You really can't argue with that. And then from there, they're stating their strategic goal to be a leader in health equity and their objective to eliminate disparities. And then they can talk about what disparities they have and what they want to do about it. Next. So you've stated your shared values. Now you want to describe the disparity that you sought to address. And ideally, you would show stratified data for your population. Here's how this population was doing. Here's how that population was doing at the beginning. And here's how they were at the end. But again, you can't always do that. So if you can't do that, you can use published national, state, or research data to show why it was important for you to do your work focused on a specific population. Really important when you describe the disparity to avoid broad terms like minority populations or disparate populations. Oftentimes we'll do that in our work teams, with our colleagues as a shorthand. But you really want to be more specific because we have found in the Disparities Learning and Action Network messaging, when we've tested our messages with the diverse colleagues, that those terms tend to be offensive. And there's no one term that's really acceptable to everyone. So just say which populations you're talking about specifically. So for example, here in this example from ARC, we're looking at what are the differences between different groups in people's understanding of the instructions they got from hospitals upon discharge, and you can see the total white, black, Asian, let's see, that is Native Hawaiian, Alaskan, American Indian, Alaska Native, and multiple races. Next. I forgot to say on the previous slide, we'll stay here though, but if you're doing fancy modeling, you might wonder if you should control for socioeconomic status. And the Disparities Solutions Center has a great report about measurement of disparities that Naya will post a link to. And they say, don't do that because you really need to show what the differences are between groups, and don't ignore that. Don't ignore those differences just because some of them are related to socioeconomic status. And they explain it much better than I do. And another way to describe the disparity is to show it on a map. So here you see an example from Health Insight Nevada, in QIO for Nevada, and they are showing which parts of the state had more Medicare beneficiaries with diabetes who were part of the priority populations they were focusing on. And here you see the shorthand of disparate beneficiaries, and it's perfectly fine to use that language among colleagues who are in the same QIO world and know what that means. But if you're preparing a communication product for a broader audience, then you can say specifically the names of the populations. But nice work on that map, Health Insight. Next. And this might be surprising. We often hear advice to use graphics to make information pop, but I recently attended a one-day course by Edward Tufte, who's a specialist in visual presentation of information. I will post a link to that, really good course. And first of all, he hates PowerPoint, so he would not like this slide. But he says, for small amounts of data, omit graphics, cite data in line with text instead. So, for example, here we say diabetes affects 9.4% of the U.S. population and 28% of the Medicare population. You don't need a pie chart to show that. You can write it in line with the text, and you understand what that means. And then afterwards, we list the specific groups that were affected, particularly affects African Americans, et cetera. So just listing those groups, as I mentioned before, instead of saying, oh, minority populations are more affected. Next. And if you have a success in health equity, it's a good idea before you brag about your successes, before you gloat about your results, to convey the seriousness of what the disparities are causing. And someone who has done that really well is Rear Admiral Chris Buchanan. So he was sharing a really big success. So it's a report that was published in 2017 by CDC and Indian Health Service. And the report shows that through basically 20 years of work, they've managed to finally halt the progression of diabetes among American Indians and Alaska Natives, and plus they have reduced the number of complications that result from diabetes in these populations. So great results and amazing. But before sharing that result, Chris Buchanan shared how diabetes affects Indian country, and you see the statement here on the slide, and the piece that really gets me is many of us have relatives or friends who require dialysis for diabetes-related end-stage kidney disease and must travel long distances to a dialysis center several times a week. I'm touched by those words. I can visualize that long drive and so many times a week and how much it affects your life. And I appreciate that. I think that's powerful, and it's a great practice that I want to adopt. Next. So there's some pitfalls in communicating about health equity. Again, not everyone's on board with addressing disparities, furthering health equity, and there's some language that can cause audiences to really be turned off and to dismiss the disparities as a result of either genes or personal failings, or maybe it's just something academics are concerned about. Maybe it's just a political thing. So let's avoid those hot buttons. Using shared values, as we mentioned earlier, is really helpful. Plain language is really important. Especially if you're talking with your colleagues who are focused on health equity and you're talking about social determinants of health, it's fine to say social determinants of health in that setting. But if you've got a message for a broader audience and you say social determinants of health, half the people are just have their eyes glazed over and you've lost them. So just use plain language like, if people don't have enough food or they don't have a ride to the doctor, you can say that. All right, next slide. The other big turnoff for about half the people that you might encounter in a broader audience is if you dwell on the unfairness or the outrage of disparities. And yes, I get it. I'm outraged and disparities are unfair. But if you focus on that, you've lost half of your audience. So what you want to do is for a broader audience, focus on the benefits of addressing disparities and describe, as that chapter in the National Academy of Sciences report, describe the mechanisms by which disparities occur. Why is this happening? So here's an example of something we wrote. Maybe it's not the best piece of writing ever, but we wrote in a Clean Times article, getting enough sleep helps to regulate blood glucose, which can prevent or help to manage diabetes. So there's the benefit, addressing sleep disparities. Someone once wrote, sleep is for the rich, and a lot of people just don't get enough sleep. And then lest someone should say, oh, well, people should just get to bed earlier, then we add the explanation that juggling multiple jobs or working shifts can make it harder to get enough sleep. Next slide. In addition to better than sharing hypothetical reasons why a disparity occurs, ideally you want to share what's actually happening in your population that's causing the disparity. So again, we'll come back to Navan Health. They did a quantitative analysis on their charts, and they saw that readmitted patients had fewer case management visits. A lot of them lacked a support person at home. They also had more comorbidities, and sadly, this resulted in greater mortality. Next slide. So they also did a qualitative analysis, and they had conversations with patients and care teams, and they learned, confirmed, first of all, lots of patients are home alone, and then patients were afraid of calls from the hospital. They're calling to see how patients are doing after after their discharge, and the patients are thinking, oh, this is the hospital calling to collect on a bill. They also learned that a lot of patients don't have a primary care provider near their home, so they can't follow up with primary care. And then even if they do follow up with primary care, they're getting conflicting messages from their primary care versus what the hospital said. And then patients said, well, it's fine if you call us, but we need a number to call you in case we have a question or a problem. There was no contact point at the hospital. So good to know. Next slide. All right, so now we know the causes, so we're ready for solutions. Novant Health provided case management for home alone patients or high-risk patients. They set up primary care appointments before discharge, and for those patients who didn't have access to primary care, they connected them with home health. And then they created a Care Connections phone number that works both ways. They can call you and you can call it. And they told people, you're going to get a call from this number, and it's not to collect a bill, it's to check how you're doing, plus you can call that number if you have a question or a problem. And those improvements were offered to all patients, not just African Americans. Next. With the results that we saw earlier. Well done, Novant. Next. All right, and for QAOs or other organizations, your results may look different. So, for example, as I said, we can't stratify, or if you have succeeded, please tell us because we would love to hear that success. But for the QAOs, for example, from the annual report, we know the number of beneficiaries who completed diabetes self-management education. We know how many educators were trained on that curriculum. We know how many languages the classes have been taught in, and that's something to be proud of. Next. And don't forget that personal stories and testimonials are helpful. Alexa mentioned that in her presentation. I won't read the full narrative, but this is a great story from a beneficiary of a DSME class. Just make sure you get permission to use photographs and story. And permission is not just a signature on a form. Have a conversation and make sure the person understands how you're going to use their picture and their story. Next. All right, and this is a really important point. You don't want to paint the people who are benefiting from your work as victims or passive recipients. We learn from each other. We benefit from interacting with each other. And this is a great example of that from an award-winning campaign from Dubai Cares. There was a study of how do people in countries that receive international aid, how do they respond to messages by charities? And this was the message that was most appreciated by people in countries that receive aid. And this beautiful boy, he looks like a prince, and he looks so bright, and he says, I can teach you to make a car from a plastic jug. Can you teach me how to read? And you can go to their website, and you can actually see this boy showing you how to create this car from that plastic jug. So really good idea to highlight strengths and reciprocity. Next. So we didn't do it as well as Dubai Cares did it. The Diabetes Empowerment Education Program was first developed within the Hispanic and Latino community. And so when Hispanic Heritage Month rolled around one year, we wanted to make sure we mentioned that in a story in the Twin Times, that in this solution that was developed by Latinos, now everyone benefits in the U.S. Next. Okay, most important, test your messages. Test your messages with some members of your intended audience, or even if it's just one person from your intended audience, that's better than nothing. And especially for health equity narratives, test your messages with some of the people you're talking about, just to make sure the message is respectful and helpful. And then consider unintended audiences, and that's true for any message, not just health equity. Think about who is the last person that you would want to see your message? Who's the person you hope will never look at your message? And then assume that they're going to see your message because we're all very connected nowadays. And then maybe you modify your language a little bit to make sure that person understands what you're talking about and to help them have a more positive reaction to your message. Next. All right, but most importantly, don't be paralyzed by all this advice. I want you to share your health equity successes. Dress something. It doesn't have to be perfect. You can improve it with some of these tips. But just get started sharing your successes. Things will get fine-tuned over time. You can start, as Alexa mentioned, on a small scale. You can make posters. If you're a healthcare organization, share this with your patients, share with provider teams. And by the way, transparency with patients is really helpful if you're doing a study to reduce disparities. Let them know that you're working on that, and they might be able to help you to achieve your goal, and they might be happy to see that you're working on it. You can share in staff meetings. It doesn't have to be really public. We have sharing calls in the QIO that are, some of them are open to the public, some of them are just for QIOs, and we're going to have an Outcomes Congress series for the QIOs during those sharing calls, so feel free to share during those calls. We have an upcoming public Disparities Land call, June 2019, so share with me what you might want to share on those calls. You can share it in chat, or you can share by email. My email address is at the bottom of the slide, and I was going to put it in the chat. There is the CMS Health Equity Awards. The deadline has passed for this year, but you can prepare your submission for next year. Maybe you'll be recognized at the 2020 Quality Conference. There's other professional conferences. Maybe you can work on a peer-reviewed publication. That's very labor-intensive. But some of you have developed Squire reports who are in the QIO world, and those could be turned into peer-reviewed publications. And some of us are working on a disparities paper for across the QIO program. So if you have something to contribute to that, I'd love to hear from you. And of course, report your successes to your project officer quarterly if you're a QIO. There's my email address, and I hope this information has been helpful. Thank you.
Great, and thank you so much, Melanie. That was a lot of awesome information and tips for all of us to keep with us and while we move forward, and also different things to utilize. There are ways that we can move forward with the health equity successes that we have. And a couple great messages in the chat about your positive feedback and pointing out the real-life impacts are really important to note as well.
Thank you. It's a lot, I realize, so don't let advice paralyze you.
Yes. Great point. Thank you. And so moving on to the next slide, we're going to hear from our last speaker, Brenda Jenkins. She's a Senior Program Administrator for Health-Centric Advisors, the New England QIO. She is a regional lead for Everyone with Diabetes Counts initiative and oversees the state-level QIO work on cardiac care and immunization. Brenda, you have the floor.
Thank you, Nora, and thank you for the opportunity to share our experience engaging the disparate population here in the New England area. I'm just going to preface my presentation by saying in 10 minutes I can't touch upon all of the strategies that we use, but certainly will highlight some of the more effective ones. Next slide, please. So as we started the scope of work, first we needed to understand what our population was in New England. And when we took a look at the data, the three northern states, Maine, New Hampshire, and Vermont, you can see that 90% or more of the population was Caucasian. So defining disparities in the north from a racial or ethnic minority perspective with these low numbers didn't really match up. This geographic area is more spread out, and they were more rural populations. And even when we look at our three southern states, Massachusetts, Connecticut, and Rhode Island, the racial and ethnic minorities numbers were low. The three highest that did rise to the surface, the top one was the Hispanic Latino population, which was representative as 12 to 16% of the population, followed by the African American population, which is about 8 to 12%, and then the Asian population, which was about 4 to 7%. Next slide, please. So the next thing that we needed to do after we've defined our target population, the question became, well, where do we find them? What community partners do we have established relationships with within this population, and who do we need to outreach to help us foster those connections? And we wanted to make sure that we were using a broad lens for that outreach. Next slide, please. So we had well-established relationships within the Latino and Spanish media groups. So, for example, in Rhode Island, we had a relationship with Latino NPR Radio that had over 100,000 listeners, and a Quintus newspaper was a new partner for us, and they had over 150,000 in their distribution list. And the healthcare insurers were another group that we partnered with, particularly in Massachusetts, with the Latino health insurers. All of our states worked closely with their Department of Health, Departments of Rural Health, Health Equity, and then here in Rhode Island we have 11 identified health equity zones that are funded by the Department of Health here to foster improvement in diabetes, cardiac, and some other health initiatives in empowering people. Then there were the health systems, like the federal qualified health centers that provided services to a lot of our disparate populations. And then community organizations, whether they be faith-based organizations or organizations such as Progreso Latino, Spanish-speaking senior centers, or Higher Ground International, and I'll talk a little bit more about those later. And then the housing facilities, which was an area where we found a lot of our disparate population. There's the New England Resident Service Coordinator Group, which is an organization that has the resident service coordinators that manage these facilities. We partnered with them to bring educational programs into those housing units to service this disparate population. Next slide, please. So we also wanted to make sure that we were looking internally as well. Targeting a disparate population isn't just specific to one task. It's something that we're all doing. So how can we leverage the work for all of the tasks to try and reach the healthcare community? We did that in a number of different ways. So whether it was sending out professional newsletters to physician office, long-term care, home health agencies, the medical societies, to share our Spanish-speaking material, or whether it was attending professional events, rural roundtables, posting information on our website, sharing it in person, using social media, and then our learning management system, which is home to a number of educational programs for healthcare professionals, including one that we put on there for health equity and health literacy. Next slide, please. We also wanted to make sure we're reaching the beneficiaries and getting that message out there. So again, we used social media, both English and Spanish-speaking newspapers. Senior Digest was one of those, and the Apprenticeer Spanish-speaking newsletter. We attended a number of health fairs. Because we were everywhere and anywhere we could get our messaging out, word started to spread that we offered materials that were beneficiary-facing and for Spanish-speaking people. So we were getting a number of requests to come and participate in their events, their Spanish-speaking health fairs and so forth. And our motto was never to say no. So I can't even tell you how many health fairs, flu clinics, and neighborhood educational events we attended. We also created newsletters that were specific to the beneficiaries or the residents. One in particular had an immunization-themed word puzzle to try and get them more engaged in understanding about immunization. Again, we used the partnerships with Latino NPR radio station. I'll talk a little bit more about that. And we even had a program on English radio as well. We brought a lot of materials to our World Diabetes Day work also, which we'll talk about a little bit more in detail. Next slide, please. So when we look at the diabetes self-management education and the population, you can see it's no surprise by the data here that in the north, it was the rural and the dual eligible population that really was our target population for completing the course. And in the southern states, it was more based on the ethnic and racial disparities, the low-income zip codes, the health provider shortage areas, and the dual eligible. Next slide, please. So if we drill down specifically to the Spanish-speaking population, you can see by the blue bars that reflects let's start with the orange bars. That reflects the percentage of the population that speaks Spanish in the home. And the blue bars represent the percentage of DSMP, or Diabetes Self-Management Education Program completers, that speak Spanish in the home. So again, in those 3 southern states, we made a very strong effort to try and reach out to the Spanish-speaking community and engage them in the DSMP work. Next slide, please. So another effort that we instituted was to create a DSMP newsletter. So this was for our leaders to try and promote continued engagement by them, to share best practices, updates, success stories, and we did this through the newsletter. You can see from this slide there's a shot of one of our newsletters, and the success story this particular month was on the diabetes self-management class, helping a Hispanic couple discover healthy eating habits. Next slide, please. One of our strongest Rhode Island partners in the Spanish-speaking community is Delia Cruz Rodriguez, who's pictured here in this newsletter. She was highlighted as our Leader of the Month. She works at Progreso Latino, which is a nonprofit that supports the Latino and immigrant communities in Rhode Island to achieve self-sufficiency and socioeconomic progress through transformational programs. So offer the DSMP classes, and we've taught a number of their staff to be leaders. And Delania, if you are on the call, I invite you to share what your experience has been in the chat box. She has been a tremendous partner to us, to reaching out not only in this task, but to others as well. Next slide, please. And pictures do tell a story. This, you can see here, is a graduating class from DSME of one of our Spanish senior centers. Next slide, please. And this one I'm particularly proud of. This was a Spanish-speaking DSMP class that was taught here in Rhode Island. And the person that is standing at the front of the class speaking is actually one of the participants who was so grateful for this class and so excited about it that for graduation she had written a poem to talk about what her experience was and how grateful she was. And that's a clip of the poem that she had written, and I apologize that the font is so small it may be difficult to read. Next slide, please. This is a class here of graduates at High Ground International. And High Ground International is a nonprofit organization here in Rhode Island that services immigrants and refugees from West Africa to empower them and to advocate for them and help them educate and adopt into this culture. So I was actually one of the leaders, and this is one of the most rewarding classes that I've ever taught. Culturally, they have a very specific diet from Western Africa, which is very high in carbohydrates and in fat. There was somewhat of a language barrier here because the folks did speak a number of different dialects from Africa, and they had very limited English, but we're able to understand what we were trying to relay to them. And during the 6-week class, one of the participants had come in and said her sister had had a stroke the week before, which was why she hadn't been in class. And it was very striking as she shared this story to say she has learned so much about their diet and what they need to do to change their diet. They're a very close-knit family, and she spearheaded those changes within the family to go across the board as to how they could make changes for a healthier diet as a result of the class and a result of her sister's experience. Next slide, please. Our physician consultant, Dr. Chris Campanile, was one of the folks that we had host these educational programs on the Latino NPR radio. You can see here the list of the 5 topics that were covered on different 1-hour programming, and there was a call-in for the second half of the program so that he would answer questions from the community about their health. It was very, very successful. Next slide, please. We also partnered with a bilingual endocrinologist, Dr. Richard Carrier, and he, 1 month, had written an article for us on diabetes within the Spanish-speaking population, what the signs and symptoms were, where they could go to find some support, and maybe some of the changes that they needed to make to have a healthier lifestyle. Next slide, please. And this is a promotional postcard that we used for World Diabetes Day. We also had materials in Spanish as well. But this event, this past year, we worked with a number of local and national partners to put this on, and this year we moved it to a larger facility, which was the Warwick Mall. We had hundreds of people come in attendance, and through our partnerships, we were able to offer free flu shots, blood sugar screenings, blood pressure screenings. With the Lions Club, we did free eye exams. We had cooking demonstrations, how to shop on a shoestring budget. We had exercising demonstrations, and then a number of other tools and resources that we offered to the community. It was really well received. We had a celebrity guest speaker come and talk, who is an NFL former champion player with diabetes. And through the sponsorship money that we had raised to hold this program, we were able to donate thousands of dollars to a group called charitable donation to Clinica Esperanza, which is a free clinic for the Spanish-speaking community that services a lot of folks with diabetes. Next slide, please. This is just my contact information, and again, I thank you for your time and attention.
Great. Thank you so much, Brenda. And that was fantastic to hear, and those pictures are really, really powerful. So it's great to see that they were equally as powerful to the audience members that are chatting in. So thank you for that as well. And in a few minutes, we'll be able to close the formal portion of the call. And so we'll have a facilitated discussion. And you'll be able to press *1 to call in with questions, or you can keep posting your questions in chat. And so to prepare for the discussion, please take a moment to reflect on what you heard today. Next slide, Patty. Please post any questions, and I'll give you a moment of silence so you can type in your questions. I'd also be interested in your key takeaways from this call. So if you would like to post those in chat as well, feel free to do so. Next slide. All right. So did we meet our learning objectives? Or maybe you can help us make sure we've met our learning objectives. So pick one question and answer it. What's an example of something that you have learned that you can communicate in 6 months? Can you remember one strategy for effective communication about successes in general? Or an additional strategy about communicating health equity successes? Feel free to take this time now to chat in and rate your strategies for communicating success, or also maybe some things that are worth sharing. And consider how cultural and structural competency helps to address the disparities. Thank you. We've got it. Lively chat. This is awesome to hear from everybody. As always, your comments and questions are welcome here. Great. And feel free to continue, but moving on to the next slide. One last thing. Think about how you leave today in action. You can write your own call to action, or you can borrow one of the ideas on the slide. For example, will you start or continue collecting staff and patient stories, or would you co-craft your messages with members? I know some of the audience presenters spoke on resources that they had, and so we can connect about communicating or sharing those as well. All right, moving on to the next slide, and recognizing it's the top of the hour, so we're wrapping up right now, but this is a call for future topics. And so let us know if there's specific topics you'd like to hear about on Disparities Land. If you like this topic, if you'd like to hear us go in depth more about a specific area, please email or chat in with the ideas. Next slide. You can also follow the TOM program on Twitter. We'll be active on the Twitter during the upcoming holiday months for those evenings. We're to very serious. And at last, this concludes the portion of it. And if you would really like you to stick around for the open conversation, and we'll be able to address questions we've been having in chat and share more on this open conversation. So remember that this is also part of the 1.5 hours. Right, next slide. I guess yeah, thank you guys. You're still here. Please post in that me if you're still here or here so I get an idea of what's going on for the next half an hour. Awesome. We've got a lot of people on the stage. Awesome. Now, I understand that there's a lot of interest in yeses coming into chat. I'd like to turn it to you to share a couple of the main or key takeaways and calls that you've seen coming into the now.
Yeah, sure. So first, we have such an awesome today. There's so much participation in chat, so just want to thank everyone for keeping the conversation going. The first thing I did notice was kudos to all of our speakers. All of our speakers have gotten multiple compliments on their presentation. So it seems today and the information that we shared. We have a few questions that I can go through. One first one that I'm going to be on, so I apologize if I'm improper, but the first one that I saw, and it seems to have garnered some interest from other people, is question from the presentation that Melanie gave, and it's asking about the young men Edward work in one-day course, and I think Melanie mentioned that he does not like to use PowerPoint. And so many are attendees wondering what they'll use when he gives presentation. So Melanie, if you could answer that question.
Yeah, I'm not sure if I ever know his code. I think it's Tufty, and he uses Microsoft Word, and what he does is he pairs memo, a two-page memo for a 1-hour meeting, and sets us up on silent reading time at meeting 10 to 15 minutes. It literally helps people to get on the same page. And then after you have read this common document, then you can have a much more productive discussion, and the meeting can end there because you're all on the same page and have read the same thing. You're not pretending that you did reading. Oftentimes you get reading assignments in advance, you don't have time to do it, and then you're at the meeting trying to catch up and have listening to the presentation. But that's how it does work, and he says a reason to do that is because in PowerPoint the rate of information transfer is really slow compared to what you can do. This is one of the reasons people multitask during PowerPoint presentations, is because it's boring. Often it's not a lot of information being transferred into. You can practice reading the more you can just listening to PowerPoint presentation. I've tried to get in small meetings and it's worked, but I wouldn't save enough time in it.
Thanks, Melanie. We have another question. So, and she says she's interested in the patient how these are delivered to them, electronic versus hard copy. And I think that question, I'm sorry, was somebody saying something?
I'm sorry, that we kind of shared that on one of my slides. This is Brenda. If that's what you're referring to. We had resident newsletters for the long-term care facilities that we had hard copies of. and we delivered them through our C2.
Okay, thanks, Brenda. Carla, just let us know if that answered your question. Another question for you, Brenda, is what do we know about the literacy level of the participants in the age range?
That's a great question. We didn't do any scientific analysis of the health literacy level of the groups that we targeted. We did have our materials, however, go through our PFAC for review to make sure that they felt that they were appropriate for general population.
Okay, thank you. And then a question from Arthur. And Arthur asks, what would you suggest as a strategy for populations that don't adapt well to technology, for example, senior population? And this actually can be addressed to all of our speakers.
That's a great question, and I'm not sure in what context you asked about that, Arthur, but there's another project that I work on to help small practices, especially practices from underserved areas, to participate in the Medicare quality payment program, and they have a lot of trouble getting seniors to log on to the people because that's one of the metrics that they're being judged on. So one of the things I have heard practices being advised to do is to maybe engage a family member or someone who's a care partner to log into the portal for that person. For quality of care, my preference would be to use the medium that the patient prefers. But that would be a great question to ask Patient and Family Advisory Council, or PFAC, as Brenda just referred to. I'd love to hear what patients have to say about that.
Would any of the other speakers like to address that question?
This is Brenda. I think that's a great question. We certainly can bring that back to our PFAC. I will say that I work on a number of different projects, and I don't think that there's a single solution to engaging a patient and educating a patient. We know when they walk out of the doctor's office, they retain about 25% of maybe what was told to them. So what we're working on is to create tools and resources that they can take home, that they're hands-on, that the provider can review with them. So, for example, we're working on a cardiac toolkit right now, and the educator in the physician office would be giving them education. So as much as they could absorb it that one time, and then they take that home with them to review. They come back, they talk about it again at the next visit, and then they build upon that. I don't know if that helps answer your question at all, but certainly technology can be challenging for the senior population.
Hi, this is Alexa. I'm also chiming in here, and I would agree with the other speakers and reiterate some of the suggestions they've made. I also find that things that are tangible, that you can make in tangible forms that they can walk out with from their visit can be very helpful, and the patient-family connection is also incredibly important. So I would be interested to see what those groups that focus on ACE, what they have found to be successful. And I can only imagine that this challenge is going to persist given the fact that we're moving to these electronic mediums. So great question. Thank you.
Thank you. I'm just going to go up. We've had a very active chat session, so I'm just going to start from the bottom and go up. I wanted to bring attention to everyone that Michelle White shared a resource regarding health literacy level. It appears to be a nationwide map of literacy level by this track, and she also included the link. So if that's of interest, please check it out. We had some discussion about community health workers and their helpfulness in working with specific populations. And so, yeah, a couple of people chime in on that. And if someone has any questions or anything regarding community health workers, you can put it in chat, or you can press 1 on your telephone keypad to enter the teleconference queue. We had
sorry, Naya. That's a segue. Maybe we can check in on chat on the telephone queue first, and then we can go back to the chat.
Sounds good.
All right. Awesome. So, are there any questions in the teleconference queue?
Yes, presenters. We have a question from Lisa Kopeg. Her line is now open.
All right. Awesome.
Lisa Kopeg, your line is now open.
Lisa, if you're on the line, you've now been unmuted. All right, maybe your question has been answered. So, Lisa, your headset is not working. All right, would you like to chat in your room? All right, so Lisa, okay, thank you, Lisa, for answering. All right, Naya, let's move on to the next question in the chat. Thanks for pausing.
Yeah, sure. So we have another question, and I'm sorry, I just put it this way. I did not actually mention up the name, but the question is, are there any other populations we may want to consider? So we mentioned a couple of populations, and I believe specifically, Melanie, you listed some in your slides. Are there any others that we should consider, or maybe people can put that in chat, or again, press 1 on your telephone keypad to enter the teleconference queue if they have any populations that we hadn't discussed today that they think we should acknowledge and try to alleviate disparities.
I'd love to answer this one. I really appreciate Yeli joining us from the CMS Office of Minority Health today. Thanks for that question, Yeli. So the Queen QIOs have at times identified specific pockets of population that weren't initially defined priority populations, but they had great needs in the area of diabetes self-management education and cardiac care. And Karen Senkate knows all about those. So Karen, if you can post some of those populations in the chat box, that would be helpful. But my recollection is one of the population was Russian immigrant population. I also know that in New York City, there's a group of South Asian people of South Asian origin who had particular needs in cardiac health. And then I like to think of disparities not just in terms of race and ethnicity, but also occupation. So, for example, in Massachusetts, there have been initiatives that have focused on women working in nail salons. They're exposed to fumes all day long, and terrible working conditions. And if others can think about population groups that we might focus on, that would be helpful. And I see Rachel saying disparities by location too. Yeah, because you can map the disparities and you can see where there are pockets of population that are in need of additional support from the data there. So you can be agnostic about what the population is and just say people living in this area. And it says from Rachel Eichenbaum's provider shortage. I always forget what the H stands for, but healthcare provider shortage area. What it is.
Yeah. Okay, so moving along, just to mention some other comments that we've gotten through chat. There have been there's a lot of chat talking about the stories and how important patient, family, and caregiver stories are. And and how these stories help people shape, their stories and help people share values in the messaging. And then Karen mentioned that, suggests that we involve at least someone from the intended audience in creating messaging and determining the format. And so that goes along with what you mentioned in your presentation, Melanie, about testing the message. Let me see, just going along. Gina mentions, suggests that we lead with a statement of shared values and messaging that is applicable and relevant to the audience. And so I believe, too, that was during your presentation, Melanie, about shaping your message and using language that that's agreeable to everyone and trying to avoid the hot button issues. Rachel suggests that we use language that all can understand. And there's a lot of talk about the ways that we use language and how using different languages has different effects. Using different languages when we communicate to different audiences is also suggested, in addition to using plain language. Let me see. I think that's it for right now that we have on chat. If anyone else has anything they'd like to share or any questions they'd like to ask, please put them in chat. Otherwise, you can enter the teleconference queue by pressing *1 on your keypad.
Thanks, Naya. And I'd like to give a few reminders before we can address, Arthur, your question in the chat. And just to make sure we're meeting the learning objectives, feel free to start conversation or continue with that in chat. And thinking about offering key points, like success worth sharing can be as simple as a single story from a person who benefited from your program. You can also share how many people you've reached from populations you were aiming for to reach. And the next learning objective for effective communication strategies, thinking about those goals and deciding what successful promotion looks like. So we discussed the flyers and also the patient stories, and what does that look like in your community that's effective. So moving on from those learning objectives, let's go. Arthur has a question in the chat about populations that don't adapt well to technology. If anybody could share the resource you mentioned about the Patient Advisory Council.
This is Brenda. I'm sorry, I don't understand the question about the patient.
No problem. No problem, Brenda. So I believe Arthur is mentioning there was a resource that the PFAC, or the Patient and Family Advisory Council, was able to share, and Arthur just mentioned that he was able to find it in chat. So, yeah, thanks, Brenda. But I believe we were discussing a resource that the PFAC was able to review so that it was appropriate for level of health literacy. Awesome. Are there any other questions in chat, Naya, that you've seen?
No, I just saw that Michelle posted another resource for everyone. It's a mapping resource that apparently identifies areas of disparity using the Area Deprivation Index. And so there's a link for anyone that wants to check that out. And then Arthur mentioned that he got the answer that he was looking for, so he thanks everyone.
Great. Yeah, and I'd like to turn it to the speakers, as you've been hearing both the conversation and the comments going on in chat and all the great insight we've gotten from sharing and communicating health equity, disparity successes. Is there anything else that you'd like to add, share with the audience or each other?
Well, this is Melanie, and I'd like to say this has been a really great audience. I really appreciate everyone joining us and participating in the conversation. I enjoyed listening to Alexa's and Brenda's presentations. In the flurry of preparing for my own presentation, I missed some of the key points, and so I will bear in mind your advice, Alexa, and Brenda. I really love that poem. I love that a poem can be an outcome.
Yeah.
And it can be a health equity success. That if your program has touched people that deeply, that they're writing a poem, that's a success worth sharing.
This is Alexa, and I couldn't agree more. I love that poem, and I think that speaks to our humanity and how we can share things that are happening to us and that are happening in a way that can be positive with positive outcomes, given the challenges that we're all facing and how different they all are. Finding ways to connect and using stories to do so can have tremendous impact on those that might not have the courage to come forward and share their own story, but they can find it relatable, and then you can use after a while you have a collection of stories, and you can start to begin to show success in metrics, and then it turns into that data that everyone is so passionate about collecting these days, which then leads to funding or can lead to expanded research. And it really does begin with stories and how we tell those stories. So I'm grateful for this opportunity to have spoken today and listening to the other two speakers. Thank you, Melanie and Brenda. Your insights are incredibly helpful for me as well. So thank you. Thank you, everyone. Thank you to the participants. You've been great. Just as Melanie said. Thanks.
Awesome. And thank you so much. Yeah, it's been great to hear about different ways that individuals and the power of the individual or human story can. So I'd invite you all as well to share the outcomes of those learning objectives. And the last one that we haven't touched on yet in the reflection is, what is an additional strategy for communicating about health equity successes? And I'd love to hear from all of you. What is one thing that you might be taking away from this call and maybe adopting in your own community? Or what is one thing that you are really intrigued by and are interested in looking more into moving forward? Thanks, Karen, for your comments that the messages that were shared were inspirational. Alrighty, it doesn't look like we are getting too many more chat comments into the box. And so I just want to thank everybody again for joining us today and for taking that time to learn about how we can communicate those health equity successes. So thank you again, and I look forward to seeing you all on the line for the next call and at Quality Conference. You'll be there. Thank you, and have a great afternoon.